So welcome, and we're just waiting for the first slides to come up, and then we'll be ready to start. So I think we have the first slide, and we'll start now. So I am Dr. Mark Rickenbach. I'm a GP near Southampton in England, and I've been interested in continuity of care for some 30 years and how to achieve it. But it's only when I've come across the Health Foundation programme that I've really seen how it could be achieved. I'm also a Professor of Healthcare at Winchester University, and today I'm the chair of the webinar. This is our second webinar for the Continuity of Care programme. And I'm the clinical champion for continuity of care at the Royal College of GPs. The Royal College of GPs is the learning partner for the Health Foundation, and it's the Health Foundation programme, and they have funded it. And I'm going to pass over to Candida Pereira, the head of improvement programmes, to talk about the programme and bring us up to speed with it. So thank you, Candida.
Hi everyone, I'm glad for you to be with us. So I'm Candida Pereira, I'm the Head of Improvement Programmes at the Health Foundation, and we're really excited to be part of this event and hearing the stories and experiences from teams from our increasing continuity of care general practice programme. So let me just give you a bit of a background in terms of how the programme started. I think the programme was launched in 2019 with 5 groups of GP practices, and they were awarded funding to explore how improvement approaches could be used to increase continuity of care for their patients. And this was really inspired by a Health Foundation piece of research which showed a reduction in emergency admissions for ambulatory care sensitive conditions for those who received higher levels of continuity of care. And of course, we know the world looks really different now to what it did when the programme was launched. COVID has had a significant effect on primary care in many ways, with a huge refocusing on COVID response on vaccinations in the delivery of this year. But I think it's been a real testament to the team that, they've managed to flourish despite such challenging conditions. And we're really proud of the learning and insight and collaboration generated through this programme. Although today we're only hearing from 2 of the teams, OneCare and Peer Health, there has been so much great work from all the sites. St Leonard's in Exeter, Valentine in South London, and Morecambe Bay. And they've really come together to help draw out key themes and learnings from the programme. I think it's very key to say that as the programme comes to an end, we're really excited to share that learning and insight with you over the coming months for you to use and apply. But as we emerge and recover from COVID, continuity has a key role to play in how we think about relationship-based care, digital consultations, workforce, health inequalities, to name but a few. I hope today that this webinar will really spark some really great ideas and conversations about the way in which continuity can be part of your local context and the benefits it can bring and the steps it can take to make it happen. I really want to take the time to thank you to RCGP for organising this webinar as part of the role as our support partner, St Leonard's, Valentine, Morecambe Bay for their great contributions to the programme, and to OneCare and Peer Health for joining us to share their projects. I'm going to hand back to Mark, and he will zoom through the presentations with the 2 sites. Thanks once again.
So thank you, Candida. That's very nice, and I appreciate the thanks. The paper you mentioned was the Isaac Barker paper, and that paper was the one that triggered the programme. In that paper, they noticed this association between continuity and urgent care admissions. And for every 10 healthcare consultations, if 2 more were with the same GP, there was a 6% reduction in GP emergency care admissions. So it's worth bearing that in mind. And the other key messages are there, which are emerging from the programme, and you're going to hear about them today. But the results from our 5 sites are emerging. Some sites have finished, like Valentine Health, and other sites, like Peer Health, are continuing on until December time. Also, the qualitative and quantitative analysis that's been done externally is being analysed at the end of the programme. So what you're going to get today is the initial impressions, the initial reports, and there's more to come yet. The key issues and key messages we've got today are that the evidence for continuity of care is there, and it's such, and you'll hear more about it in a minute. And it's so compelling that actually the programme is about how to do continuity, how to introduce continuity in day-to-day real-life general practice. And that's what all the programmes have been working on. So the evidence is there, and the conclusions are that continuity is achievable, and it's achievable by all of us in different ways. But now, thanks to the toolkit that you're going to hear about, it is something we can all do. So I hope you'll go to that toolkit. Mid-July it's coming out, and you can access it through the college website. So the agenda today, well, we've got two sections. You're going to hear from OneCare and then peer health. And in each section, you're going to get a GP lead who's introducing that section and will tell you about the GP perspective. And then you're going to hear from the project teams about how they put continuity in place and moved it forward. And at the end, we'll have some question and answer session and discussion. So use the chat box on the right or the Q&A portal that's there. Okay, so next slide then. So you'll see that, or you'll hear that there's lots of different tools. And so we need to make it clear what the definition of those is for you. Okay. And I also want to re-emphasize what Candida has said about the fact that there are 5 sites involved. And all sites have been facing similar issues, and they've come to different solutions to address those. And those solutions will be then available on a wider basis. So, for example, St Leonard's in Exeter has been working for many years on continuity and produced the SLIC, or the St Leonard's Index for Continuity of Care. And that work has sat alongside work by OneCare using the usual provider of care, or UPC. And that's contributed to a tool which can measure continuity of care in your practice if you're using EMIS or System 1. So that will be available mid-July. And we have Morecambe Bay, led by Julia Knight in particular, along with Hugh Reeve, who have worked together to produce this toolkit. Now, OneCare today will be presenting about it, but we need to say thank you to them. And Morecambe Bay Primary Care Collaborative has also been working on reallocation tools and switching tools. However, you'll be hearing from Peer Health about it today. So it's very much a shared collaborative exercise that's been going on. Now, I want to clarify the definition of a reallocation tool, because basically you have patients coming to you and you want to identify whether they're with the right GP. It may be that they're seeing another GP more often, and therefore you need to transfer them across to that GP. Or it may be that the workload within the practice is unbalanced and the list has to be redistributed. So that is the reallocation tool that will identify that. And then we need a switching tool, which actually moves the patient from one named GP to another. The problem at the moment is this has to be done manually for one patient at a time. And what you'll hear is that people like Joe Knight at Morecambe Bay, and later on you'll hear from Peer Health, have been working on tools that will actually transfer patients across automatically. So that's the tools, and telling you about them a bit more. Now, you're going to hear about from OneCare now, and we'd like to say welcome to Jacob Lee, who's the GP lead at OneCare, and Julia Martineau, who's the project manager at OneCare. So I'm going to hand over to you, and I look forward to hearing a bit more about the toolkit. Thank you.
Hi, thank you, Mark. So I'm Jake Lee. I'm a GP in practice called Horfield Health Centre in northwest Bristol. And I've been really lucky and to be involved in the OneCare project as the clinical lead over the last couple of years. So OneCare is a federation that supports 76 practices, and we cover 1 million patients between North Bristol, between Bristol, South Gloucestershire and North Somerset. And I think my job is to remind you about the evidence that is for continuity, share our story, and hopefully help you feel that delivering continuity is achievable and worth doing for your practice, for your GPs and clinicians, and also for your patients. And share some of the learning that we've had to help you start your journey and take that first step. So when I started in the project, I was suddenly exposed to a whole host of peer-reviewed, high-quality evidence. And I was really surprised that this isn't more widely shared and cited and used to design how we deliver the care for our patients. And for me, I was struck by how this just doesn't come out in all the teaching that we have, that actually continuity is probably one of the single most important things that we can provide for our patients. So what does it show? Well, for patients, we know that it will improve the quality of care they receive. They will experience more personalised care that is provided by someone that they learn to trust, that they will live longer and reduce the need for hospital admissions or attendance in A&E. But there are also benefits for doctors. You'll feel greater value and personal and professional satisfaction of the care that you're able to give, provide higher quality care, and have a greater insight into your patient's background and community, their understanding of their health within their community setting. What we've also found here in the OneCare site is that it helps you to share the workload more equitably across the practice between GPs. And there are wider system benefits to continuity. It reduces unnecessary prescribing, it reduces unnecessary investigation, and it really helps deliver greater value care to our patients. From the surveys we've carried out, we really found that this feeling of continuity is important was replicated amongst GPs, staff, and patients, and it was really exciting to see that coming through. Next slide, please. So improving continuity does bring some challenges and potential adverse effects that we just need to be aware of. So in asking patients to prioritise seeing the same GP over access, that can sometimes lead to delays. And I always think of the elderly lady who waited a week to see me with her acute chest pain, and she'd had a heart attack, but she didn't want to belay my trust with her, and so she waited. And we have to make sure that in the systems that we design, that patients are asked appropriate questions to make sure that if they do need to see if they do see their own doctor, they're not waiting unnecessarily. We need to be aware that in building relationships over time with our patients, that it's important to maintain boundaries, and there are limitations that we as clinicians do, and patients will often think that we are magical people that can do all sorts of things, but I'm not a social worker, and I don't work in the community in the same way that many of our other colleagues do, and so maintaining those boundaries is really important. Before I started working in a practice that has personal lists, it was really interesting that you'd see patients that felt uncomfortable, that how you're relating with them or the consultation just felt difficult. And when you weren't seeing those patients all the time and they were shared amongst many GPs, that felt easier because you'd only see them sort of 1 in 6 times every time they came to the GP. When you move to using sort of a continuity or providing continuity to patients, it can sometimes feel more difficult and feel overwhelming that patient that you find challenging, or that the consultation doesn't flow as easily. They keep coming back and seeing you and seeing you and seeing you. And actually, what I've learned is that you can often transform those relationships, and by having more consultations with these types of individuals, that you can build and develop a rapport with them. Not always, and I think it's important to recognise when a relationship between a GP and a patient becomes non-therapeutic, and it is okay to agree with a patient that they might be better off seeing another GP. And I think it's important to know that we can do that. A fresh pair of eyes is important, and sometimes when you've been stuck with a patient coming back 2, 3, 4, 5 times and you don't feel like you're getting anywhere, having that fresh pair of eyes is okay, and having systems set up in your practice to enable that is important. One of the challenges, I think, in knowing our patients is that we can build up judgments or an expectation, and those judgments or expectations, how a patient is going to present, will change your view or decisions on how you manage them. And this is the most stark example is of the highly anxious patient that comes requesting lots of investigations for every symptom that they ever have. The challenge is they can still have underlying serious health problems that do require urgent investigation, and how you behave with these patients is changed by your previous experience with them. And just keeping your antennae up and awareness that happens. I think it's important to be aware of these effects. However, it's really clear that the wider benefits of continuity far outweigh the negative. And for me, a lot of these so-called negatives can be overcome by developing a role of sort of peer-to-peer support within practices, regularly discussing cases. So here in Hallford, we use lunchtime coffee and we all meet and we discuss patients who are causing us angst that day. And I think having these sort of both formal and informal ways to set up and discuss cases and share that knowledge amongst the GPs is really important. And I think it's also really important to know when it's good to ask a patient to see another GP, either for a second pair of eyes or to take over their care. For me, having moved to a practice that does promote continuity and provides personal lists, it's really made my job so much more enjoyable. And I was trying to think about why that is. And I think it's about the personal responsibility and ownership that I have to the patients that I see that make me want to think more than just the problem they've come with today, thinking about their proactive care, understanding the patient in the context of their family, and having their whole family registered with me as well. Instead of looking after 1,000 separate patients, I'm looking after 200 or 300 families. And knowing that the time and effort I put into my consultations helps build that trust and rapport and really helps me provide better care. It's transformed how I feel about medicine and how I feel about being a GP, and it's all for the better. So I'm going to move on and just talk a little bit about our project. So next slide, please. Thank you. So we started off with this ambitious bid to the Health Foundation saying that we'd be able to cover a population size of 400,000 patients. And you start the project and you think you can do it. And luckily, and importantly, we were overwhelmed with applications from practices within Bristol, North Somerset and South Gloucestershire. So we had 23 practices. We were oversubscribed. Our first step was to set up a steering group to guide the project. And this steering group was made up of reception leads, practice managers and GPs. Because we were working with many different practices of different sizes, different GP makeup, we couldn't have a fixed model or a fixed way of delivering continuity. And what we found during the project is that helping practice to understand what was important to them and what they felt was achievable for where they were, whether this was moving towards a more usual GP approach and balancing list sizes for the doctors in that practice, whether it was looking at specific cohorts of patients, such as frequent attenders or the frail and vulnerable or palliative care, and helping them focus on that, or whether using sort of developing buddy systems for those people that work more part-time. And I think our role as OneCare, which is unique, was that we are there to support, encourage and facilitate sharing of ideas. And I think the trick that we came up with was collecting those ideas as we went along. One of the biggest things that we found beginning of January 2020 was that actually having the data there to show how people are doing is the biggest and most stimulating thing that practices want. If you can show them how they're doing and show them how they're doing as individual GPs in that practice and also as a practice compared to other practices, it gets them excited and it brings out the competitive aspect and they want to do better. So having really easy, accessible, reliable data to measure continuity and measure the change over time was probably the biggest thing that made a difference to practices. We had this small thing called COVID that hit us quite near sort of halfway through the project. And certainly in the first couple of months, when everyone was deep in redesigning how they deliver their care and moving all to phone consultations, we were really worried that lots of the practices would want to pause or drop out of the project. But actually, it was lovely to see that most wanted to continue. And what I heard people say was that continuity was even more important when trying to manage patients on the phone. And doctors were able to have that picture in their head of the patient that they were speaking to. and their knowledge of that patient from the past was really helpful. The sort of the formal part of our project did take a pause for a few months, and that gave us time to sort of take stock and start to collate all the resources that practices had developed, and between the Health Foundation sites and sort of OneCare and Morecambe Bay, we started to pull together the toolkit. And if you go on to the next slide, please. The toolkit is a wide collection of all the really practical advice and practical things that we can do to help improve continuity. The usual GP tool helps extract data and gives us that reliable EMIS data that gives us our continuity scores over the last year, and it breaks it down for each GP for each month, and it's really, really helpful. Next slide, please. So when you go through the toolkit, we've worked out that you have to have a vision or an idea and get people on board with that, and there are tools in there to help you do that. Measuring where you are, both data around continuity scores, but also where your reception team are feeling, where your patients are feeling around continuity, and starting to look at some of the processes you've got in place in your practice. And then about sharing stories and ideas. And I'd really encourage you to have a look at the toolkit, because it's not sort of ethereal stuff, it's really practical things. It's scripts that patient coordinators or receptionists can use. There are education slide sets for reception teams. There's really practical stuff that helps you do it. So in my mind, there's no one way to deliver continuity, and it's about finding out where you are as a practice now and what feels right for your team. So I work in a practice that delivers personal lists, and we thought we were doing brilliantly before COVID and before the pandemic, but actually when you measure it, we were delivering continuity about 50% of the time of the consultation we provide. And over the last year, we've increased that to 70%, which is a lot of hard work, but actually just having the data there and thinking about what you can do to make a difference can make a big change. But lots of our other practices have just taken small changes, and doing something has ripple effects. And in the practices that we have seen who've focused on small cohorts of patients, what we notice is, and in the data shows us, that the continuity improves the whole practice. And it's about getting into that psyche and that ethos. I've really enjoyed it, and the journey isn't finished, and we're going to carry on providing continuity and carry on working with the practices within sort of the OneCare Federation. Julia's going to talk a little bit more through the detail of the resources that are available and take things on from there. Thank you.
Thanks, Jake. So as Jake's mentioned, we have a measuring tool for EMIS practices, and that's part of the Resource Toolkit. So you'll be able to get that free as part of the whole thing. And the measuring is invaluable because that's what enables practices to know where they are with continuity of care. So in this toolkit, there are two measures of continuity of care used. The first is the usual provider of care, and the second is the St Leonard's indicator of continuity of care. And as Mark mentioned earlier, St Leonard's is another of the projects within this same programme. And along with being able to measure continuity at our practices, the tool has some additional functionality that practices needed to help them with their continuity. So it's been a sort of evolving tool in response to what practices have said they needed. So it includes a list of the frequent attenders, and GPs then can use this data to find, for example, patients that are circulating through the GP team. So these are the patients that have no continuity, and therefore they run the risk of missed or delayed diagnosis. There is a dashboard giving a breakdown of the consultation activity in your practice. And we've included the range of results from the OneCare practices so that you're able to benchmark, because practices find that quite useful when they see the results to see how that looks against other practices. The tool also looks at the spread of consultation activity across the GP team. I'm sure many practices already look at the even spread of patients across the GP team, but this will give you data that shows how the consultation activity is spread across the team. perhaps as a GP who is seeing a much larger portion of your frequent attenders than perhaps you'd realised. So the tool helps you to relocate that activity. And shortly you'll hear from the Peer Health Project how they use that particular functionality. And as a project, we've seen practices improve continuity of care by up to 15%, which we believe is fantastic given the pressures of the pandemic and the Max Fax program. So this is a really easy to use tool using EMIS searches and an Excel workbook, and we provide a really clear step-by-step guide on how to use it. We'd like to now share with you 3 different practice journeys. All of them had the same goal, to improve continuity, but they have approached it very differently in a way that fits with their practice. Next slide, please. As a practice, how you improve continuity is down to your own circumstances within your practice. So let's look at the first practice, which uses personal lists. So personal lists are where a patient sees the same GP. It might be the odd exception where they need an urgent consultation, but on the whole, they are seeing that same GP. And I think personal lists could be regarded as the sort of gold standard for enabling that building of a relationship between a GP and a patient. So in this practice, the personal lists were already in place prior to the project. And they make that work by asking their GPs to work at least 6 sessions per week and always to work on the busy days of Mondays and Fridays. And this practice really believes in personal lists because for them, there's no greater job satisfaction than when they feel as GPs responsible for their own patients. And they've extended this through to the nurses at the practice as well. The personal list for them decreases the workload because the GP knows and understands their patient, so they don't have to scroll through the notes. They know their patients, so the consultation is more efficient. And the practice also sees the other efficiencies where the information flows very easily because the reception team know which GP to send the results to or any other correspondence. And this practice also finds GP recruitment relatively easy and believes that is linked to the continuity of care. And that is a view that has been shared by another practice in our project as well. So it's a practice that has won several accolades, and it seems to reflect that continuity of care is valued by staff and patients. Our second practice, again, we were exploring how to improve continuity within a practice. So they trial the GP buddy approach. There's just a small number of patients. So the GP buddy approach means that the patient has a GP that's assigned to them, but if that GP isn't available, they'll see the GP buddy. So the idea here is that you are improving continuity and you're reducing the number of GPs a patient sees at the practice. And you're enabling another GP to be able to build a relationship with that patient. What we learned about this approach is it takes time to set up. You have to select your patients. In this instance, they were from the frequently attending group. You've got to inform the patients, send them letters, let them know about the pilot, who's their GP, who's their buddy. And you've got to pair up your GPs. And to do this, you need to agree what's the criteria for the pairing, what's going to work well. And the measuring tool can help you here because it will tell you which GP the patient has seen the most and seen the second most. But then, of course, you need to equally distribute the spread of the patients across these GP teams that you've created. And then you've got the process change, adding flags to your system, pop-up reminders to reception. So the preparation is key, and also starting with a small group of patients and taking the time to get that preparation tested and get it working effectively, and then you can ramp up. And this is work that has had a very positive feedback from patients. So it is a good model to go for the GP buddy if it works for you. Our third practice focused on a cohort. Jake mentioned this earlier. They decided to look at their learning disability patients. And this project is an interesting one because it saw an impact of efforts really quickly. I think perhaps due to the GP lead who was very supportive of the learning disability cohort, and also to the operational lead of the practice who was very knowledgeable about the processes within the practice and knew the GP system really well, so could set up the flags, the monthly reporting and that sort of thing. So they were able in a short space of time to double the continuity of care for that group. And also what we found was that they improved continuity across the whole of the practice, this sort of ripple effect. So, and this is something that we've seen in other practices, focusing on cohort, a ripple effect that improves continuity for all of the patients. Next slide, please. What I'd like to look at now are the things that we learned from practices. So assigning a clinical and an operational lead within your practice will help you to drive that project through. Against all the other pressures that you're having to cope with in the practice, you've got some key people that are focusing on getting the activities done. Building a culture of continuity of care within the practice is key. And one of the most effective ways that we found through the project is having one of your own GPs explain to the staff what continuity means for them in terms of knowing the patient, not having to start at the beginning of the story each time. To involve patients and patient groups, we found that they provide a really important patient perspective of what happens at reception, what happens during consultation, and they can also provide you with support to the project, perhaps communicating out the benefits of continuity of care to the wider patient list. We've mentioned before about measuring, having that baseline measure, measuring progress. It's really motivating when you start to see continuity improving. And we've got the Resource Toolkit, and from that you just select what you need. It's been described by one user as giving you the cooking equipment and the ingredients for you to bake your own continuity of care cake. And finally, it is about starting small, reflecting and learning, because once you get it right, you can very quickly expand it. So that PDSA approach is the way forward. And then on the next slide, I'd like to just touch on what we've learned as a project from taking part in this program. We know that continuity does matter. As Jake mentioned, we were oversubscribed, so we know that practices were very interested in taking part. We've seen the evidence from our own surveys that we've done and those done by Mott MacDonald, and we've seen it through the National GP survey results as well. We found that where practices had a high patient turnover or where the GP team was unstable, the practice really struggled to get high levels of continuity, and I'm sure that's not an unexpected result for you. But some of our results from our 23 practices were challenging some existing ideas. So there's some research that suggests that the larger practices are less able to do continuity. We didn't find that. And we didn't find any evidence that continuity is necessarily less or lower in multi-site practices. We found that GPs working low numbers of sessions were just as able to achieve continuity levels of those working a high number of sessions at a practice. And we also have practices who are delivering really good levels of continuity in deprived areas. So what that seems to suggest to us is that the key lies in the processes that you as practices put in place. That's what really matters. And as we'll hear from Peer Health, it's about designing the front door for both continuity and access. We've learned that the quality improvement approach works. It's a methodology that practices are very familiar with, and it's a methodology that you can take and you can replicate in other projects. And above all, it takes time. We see continuity as a journey.
So thank you. Thank you to Julia and Jake for that presentation. It's really interesting, and I'm really excited about the toolkit and the fact that we all as GPs or primary healthcare teams can access this, and from mid-July you'll be receiving an email to access it on the RCGP website. So well done on that. And the message is still continuity of care has an impact. It is important, it is achievable, and we can all do it. Now there's some questions coming in already. We'll be dealing with the questions at the end after the Peer Health presentation, including one on microteams I see. And a couple of other things just to say. When you see, as you've heard, names on slides or quotes, we have got permission from these people for those quotes, and in many cases they've seen the slides, so that's really good. And of course we have results coming from other centres. So, for example, Valentine Health has noticed that the younger patients actually value continuity and want it, but they prioritize access over it. So that's an example of how we get different viewpoints and different information coming in.